Thank you all for coming out to another HRG weekly webinar. We're so glad that you are all taking the time to join us in these crazy uncharted times. We know that your time is more valuable now than ever. Each week on Wednesday mornings, HRG is committed to providing industry updates and tips and tricks that you can leverage right away. As usual, just before we get started, a couple of housekeeping items. To make sure that we honor the time that we've allotted, we will answer any questions that come up in an answer sheet that will be sent out later today with the remainder of the webinar resources, including the slides and webinar recording. This morning, we have HRG Director of Coding, Compliance, and Audit, Vanessa Brumfield, joining us to break down behavioral health coding. Go ahead and take it away, Vanessa.
Hello, everyone. Again, this is Vanessa Brumfield. I have been in the field for over 20 years, moving from coding to auditing and working with multiple specialties, including behavioral health. I've been working for HRG for about 5 years, working external audits, and now more recently coding in the audit division. This is an overview, and I'm utilizing CPT and CMS guidelines. The reason I'm calling that out is because, especially with behavioral health, state guidelines and payer-specific guidelines may be a little bit different from CPT and CMS. So anything that I am giving you is informational, and I do recommend that you check with those state guidelines and payer-specific guidelines to make sure there is nothing different. My disclaimer, all coding must be considered on a case-by-case basis with documented support of medical necessity and state regulations as appropriate. Okay, let's get started. The first thing I wanted to discuss is the eligible providers. At least for CMS, on this slide, you'll see all of the providers that Medicare recognizes as providing behavioral health services. Excuse me. State-based regulations will vary on the physicians that they will reimburse for, and also what those physicians can do. So again, I would look up state guidelines to make sure that they are not different than what CMS has on this slide. And then the other thing is I have a link here that takes you to the eligible physician. So if you wanted to go to that file, that would be a good place to take a look. Now with coding, we always want to go over medical necessity. As coders, we've heard it time and time again as providers. So just to quickly go over, medical necessity is definitely very important for behavioral health. Medicare covers medically necessary and reasonable services or supplies to treat the patient's overall diagnosis and condition or improve a malformed body member. Services must meet the standards of good medical practice for diagnosis, direct care, and treatment of the patient's medical condition, and not mainly for the convenience of the patient, provider, or supplier. As with any code submitted with medical necessity must be considered when reviewing each visit. The medical necessity for each behavioral visit should be clearly documented in the note to support the initial service and any ongoing treatment. The next thing we'll cover is, I won't be covering all the available codes for behavioral health. This slide shows what we will be focusing on today, the interactive complexity, psychiatric diagnostic evaluation with or without medical services, the psychotherapy, general in crisis, and then family and group therapy, and also the pharmacologic management. So usually the first, a question that I get quite a bit is, what should you code for the initial visit? There are some cases where either code may be appropriate to bill. So if we look at this slide, I have the psychiatric diagnostic evaluation, which is code series 90791 through 90792. And then on the other side, we have the evaluation and management codes, new patient, since it's the initial visit, 99201 through 99205. There are instances where one code may be more appropriate than the other. I would say let medical necessity and the provider's documentation guide you. Keeping in mind that with the evaluation and management, there are some providers, I'm thinking the social workers and counselors that cannot code E&M services. Each of those codes do require a chief complaint or reason for visit. Um, this helps to identify the medical necessity for the visit. So going through those, the diagnostic evaluation is a diagnostic assessment that includes integrated biopsychosocial assessment. It may include history, a mental status exam, and recommendations. If it's with medical services, then it may include additional elements for the physical examination as indicated. And there's also communication with the family and other sources. We all know the evaluation and management codes. They have their three components: the history exam and medical decision making. With the history, we do want to make sure, again, that there is a chief complaint, review of system, and past family and social that is pertinent to why the patient is there or any condition that is impacting the care on that day. The provider can also document time if more than 50% of that visit was spent counseling and or coordination of care. So again, what I would say is let the documentation and medical necessity kind of guide you into what code series is best. For the most part, the documentation does look a little different. You know, you'll have your SOAP note for the evaluation and management. The diagnostic evaluation, you'll have a SOAP note type as well. But for the most part, sometimes what you'll see, especially if it's just the assessment, is the mental status exam. Um, if you see other things addressed, other conditions, medication, that type of thing, then you can do the diagnostic assessment with medical services. Um, so for the psychiatric diagnostic evaluation, this is the minimal documentation. Um, the Behavioral Health Association, I'm sure, have their own standards of what they educate their providers on how to document for these. But for coding purposes, we do need the initial concern documented, a complete psychiatric and medical history. Usually you'll see medication and allergies, definitely the mental status examination like we discussed before, and then also the patient's ability and capacity to respond to treatment. That's an important one that we should see in the documentation. And then also the initial treatment plan of care. The 90791 and the 90792 code series can be used for reassessment as well. Now, the first code we'll go over in detail is that interactive complexity. It is an add-on code that you would report with the psychiatric diagnostic evaluation, the psychotherapy with E&M, and then you can report it with group therapy as well. This code is used when the delivery of services are complicated due to specific communication factors. The documentation should include the fact that the patient does not have the ability to interact through normal verbal communicative channels. It should include what methods were used and the rationale for employing interactive techniques, and then also the recommendations for future care. You can report this code when one of the following is present: maladaptive communication. What this is if the patient or one of the participants, probably the patient's family, there's exhibits high anxiety or a heightened reaction, or asks repeat questions, or maybe there's repeat disagreements. Also, any emotional behavioral conditions affecting implementation of the patient's treatment. And then the provider may use toys like toys, dolls for a child. This also can go for interpreter and translator services. I would caution to be careful with the interpreter and translator services because as far as CMS is concerned, it's just not, oh, they're using a interpreter and translator, so we can automatically apply this code. You really want to make sure that that documentation is showing the complexity of that visit because of the language barrier in order to use that. So again, medical necessity and making sure it's clearly documented in the note is important. The next code series is for psychotherapy, treatment of mental illness and behavioral disturbances through therapeutic communication. The goal is to alleviate the emotional disturbances, reverse or change the maladaptive patterns of behavior, and encourage personal growth and development. With this code series, you can report an additional E&M if basically medical services is also provided at that visit. Usually what you'll see in the documentation is in addition to discussing the mental illness and behavioral disturbances, there may be some medical and psychotherapeutic components in that documentation that warrants coding for E&M as well. Now, it does have to be just like anything else. Anytime we use a 25 modifier, that E&M must be separate and significant in order to report it. So we should be able to pull those E&M components outside of what they're doing for the psychotherapy. And remember, the psychotherapy is time-based. So again, documentation just needs to be really, really clear in order to report. If we look at the breakdown of the codes, psychotherapy, 30 minutes with the patient, 90832 and 90833. Same psychotherapy, 30 minutes, but the 33 is with an E&M service. So usually with the ones with the E&M service is going to be your physicians that are reporting that. What I do find sometimes is on the same day, in certain facilities, they may have um, the social worker or the counselor doing the psychotherapy part, and then a physician will do the E&M service. What I've provided for you on this table also is the reporting time range. So you cannot report these codes if it's 15 minutes or below. So for 90832 and 90833, you have a reporting time range of 16 to 37 minutes. For the next code, 90834 and then 90835, that's 45 minutes with the patient. You can report that code between 38 and 52 minutes. And then 90837 and 90838 for 60 minutes with the patient, your time range is 53 to 90 minutes. The documentation for psychotherapy services should include, of course, the time spent in the psychotherapy encounter. With that being said, I did find documentation where it says the exact time. Now, your CMS max may be different in how they want you to report that. Um, so I recommend having a start and stop time so that won't be questioned. Because it has to be the exact time, I think that's the best way to capture it a lot of the times, than just putting total time spent. But again, there may be some CMS, Medicare administrative contractors that will allow you to just to just go ahead and do the total time spent. So just make sure you look that up so you can be doing what is needed for the MAC in your state. The other part of the documentation should be therapeutic maneuvers such as behavior modification, supportive or interpretive interactions, um, a periodic summary of the goals, the progress toward the goals, and an updated treatment plan must be included in the medical record. And then also, why is the patient still going through treatment? Why is the provider recommending ongoing treatment? That needs to be clearly documented in the note. The next codes are psychotherapy for crisis, the first 60 minutes, and then 90840 is each additional 30 minutes. These codes are used for urgent assessment and a patient that has a history of a crisis state, a mental status exam, and a disposition. The presenting problem is usually life-threatening or complex and requires immediate attention. Treatment usually includes psychotherapy, mobilization of resources to diffuse the crisis and restore safety, and then implementation of psychotherapeutic interventions to minimize the potential for psychological trauma. With the family psychotherapy codes, you have two codes, 90846 and 90847. They're both 50 minutes in time frame, and one is without the patient present, and the other includes the patient. The provider meets with the patient's family, with or without the patient present. Emphasis of the visit um, is the patient's care and the family's involvement in the patient's treatment. Because as we all know, the support of the family is needed, especially with these types of conditions. So sometimes they'll bring the family in to have discussions and explain to them how they can help the patient. Reporting time, 26 minutes or more. So you can report those codes if you've reached that 26 minutes or more time frame. Then there are the group psychotherapy codes, one for family group, and then the other one is just general group psychotherapy. And it does have to be facilitated by a trained therapist. The next one is the add-on code 90863 for pharmacologic management, including prescription and review of medication when performed with psychotherapy services. That add-on code cannot be reported with the E&M codes because the E&M codes basically incorporates that component of prescription and review of medications. Now moving on to telehealth. As we know with COVID-19, I'm not going to go into detail about the telehealth because we're actually going to have another webinar next week that will go into telehealth services during COVID. But I did want to put a little slide in here just to mention that there was expansion of services. What they did was they included the group psychotherapy and the psychological and neuropsychological testing in the list of codes. For CMS at least, the place of service, you could report based on where the service would have been provided had COVID not been present. You can report with the O2 as well for telemedicine, just keeping in mind that that's the difference between payment of the facility payment versus being paid appropriately for what you would have been paid with the correct place of service. And then CMS is asking for a modifier 95. So what I did want to show you is I did put a link here for the complete list of services. Let me just bring that over. Okay, so that link will basically take you here. Oh, no, sorry about that. Let's go ahead and click. I was going to say this worked perfectly when I practiced it. Okay, here we go. So that link will take you to this site, Medic CMS site. And then once you go into this site, it will give you a list of codes. And the reason that I'm bringing this up because I would want to bring to your attention that on April 30th, what Medicare did was they included this column where it says, can audio only interaction meet the requirements? So one of the pre-questions that we receive is how would we code for that if it's audio only? And so what I want to show you is if you look at the code series, we do have a lot of behavioral health codes here. If the code is on this list, that means it's met its requirement for the telehealth service. But also, if it's audio only, what I would do is add the code and treat it like it's a telehealth service, meaning audio and video, where you would add this code and add a 95 modifier, and then add the place of service as where that service would have been performed if COVID did not exist. So this list is very helpful. And again, it lets you know how to treat the audio only for specific codes. And as you can see, all of the codes are not, does not meet the requirements. So you definitely need to look at this when you're doing some coding. Okay, let's get that out the way. So with the expansion, the telehealth was no longer limited to rural areas. It also allows the patient's home to be the originating site. And as per minimum documentation for the telehealth, verbal consent was audio only or was audio and video used, the location of the patient and the provider, and the total visit time, including any additional time spent on that encounter. So that includes the pre-work that the provider may have spent reviewing, getting things together as well. Include that all in that total time. And that is for CMS. Um, Again, your state may have, especially Medicaid, may have more stringent documentation rules and may be looking for things. So please take a look at that before you submit so that you can educate your providers on what's needed. Now, we're to the diagnosis codes. I just put some conditions that we can discuss based on the most common ones. We only have, about 30 minutes, so I didn't put very many on there. So the first one that we see fairly routinely is depressive disorder. And that one is separated into major, organic, or persistent. With major, the provider really needs to document, is it with psychotic symptoms or without? Is it in remission, full or partial? Is it recurrent? And does that include psychotic features or not? Or is it a single episode? And is it mild, moderate, or severe? We should be coding to the highest specificity, but again, that's going to depend on the provider's documentation. And documenting to the highest specificity, again, supports the medical necessity and the complexity of that visit for the patient. Another one is attention deficit disorder, which is categorized as inattentive, with or without hyperactivity, combined type, and other. A lot of the times what I've seen is just says attention deficit, it just say ADHD, honestly. But we do need it to say whether it's truly inattentive type or with or without hyperactivity. The next one is bipolar disorder. That is categorized by type 1 or 2. Is it current? Is it a single manic episode? Or is it in remission? If it's current, then does it have depressed features with or without psychotic features? Hypomanic? Manic, again, with or without psychotic features? Is it mixed? Is it severe depression, but without psychotic features? For the single manic episode, is it mild, moderate, or severe? And then again, if it's in remission, is it a full remission or partial remission? For full or partial is the most recent episode, and then we're going back to more specific depressed features, hypomanic, manic, or mixed. The next condition I have is anxiety, and this is just a lot of times you'll just see anxiety, which we know just kind of goes to the general. Um, But there are several categories. Is it depression, generalized? Is there hysteria? Is it anxiety neurosis? Is it panic type anxiety, or is it just reactionary? Um, is it due to separation, usually of childhood, state anxiety, or is there some other type of anxiety that the patient is exhibiting? Okay, so I hope that was helpful. What I have included again is my references. I included the Medicare mental health booklet and then also the telehealth list of behavioral health services, which I think will be very helpful for you. As I stated earlier, our next presentation will be by Teresa Tate. She's our Executive Director of HIM Coding, and it will be addressing COVID-19 coding. As we know, the COVID-19 coding updates frequently, so we'll be looking forward to seeing you.